Welcome back, everyone, to part 146 of the Decode Healthcare with Harshal Masterclass. I am absolutely thrilled for today's session. Now, in part 145, we wrapped up the executive capstone on health system CMI optimization, risk adjustment, and value-based bundles. We really dug into how to accurately capture the severity of illness to ensure fair reimbursement. But today, today we're shifting gears. We are crossing the boundary from revenue cycle management straight into the high-stakes world of federal fraud and abuse enforcement. This explainer is all about regulatory compliance, the OIG work plan, corporate integrity agreements, and fraud defense. So get ready, because this is exactly where clinical coding meets the federal legal system.
But real quick, before we dive into the heavy stuff, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal.
All right, let's take a quick look at today's agenda. We're covering 3 core areas. Number 1, fraud risks and audits. Number 2, CDI query compliance standards. And number 3, quality assurance and audits.
Let's jump right into Section 1, Fraud Risks and Audits, focusing specifically on the False Claims Act and inpatient coding.
You know, there's this really common misconception out there that coding errors just result in a denied claim, maybe a little administrative headache. But in reality, consistent coding discrepancies can rapidly escalate into full-blown federal fraud investigations. Documentation integrity literally means the codes assigned are strictly, undeniably supported by the medical record. Now, on one hand, we have upcoding. That's assigning a code that yields a higher reimbursement, like a higher MSDRG relative weight, than the documentation actually legally supports. Listen, this isn't just a simple mistake, it's fraud. It triggers intense payer audits and violates federal statutes. On the other side of the coin, we have undercoding, which just silently drains your revenue. When you fail to capture a valid complication or comorbidity because the documentation is vague, you're looking at lost revenue, an artificially lowered case mix index, and totally underreported hospital performance metrics.
So let's talk about the False Claims Act, or the FCA. This is the primary federal statute targeting upcoding, and the penalties are no joke. We're talking about treble damages, which means you have to pay back literally 3 times the amount of the overpayment, plus massive per-claim penalties if a hospital is found to be knowingly submitting false or fraudulent DRG claims. But it doesn't even stop there. You also have to navigate the anti-kickback statute and the Stark Law. This is where improper physician financial arrangements or even query incentives can completely taint your IPDRG reimbursement claims. The absolute worst-case scenario here? Total exclusion from Medicare and Medicare. That is basically a death sentence for a health system. So you can see why coding accuracy isn't just a billing issue, it is a vital existential compliance mandate.
Now, you might be wondering, who exactly is out there hunting for these errors? Enter the government watchdogs, Recovery Audit Contractors, or RACs, and the Department of Health and Human Services Office of Inspector General, the OIG. The OIG actually publishes a work plan that outlines their active audit priorities. And let me tell you, they heavily target inpatient hospital billing. They're looking closely at things like severe malnutrition upcoding, sepsis validation, stroke DRG upcoding, and mechanical ventilation hours. These auditors are asking one very specific question: does the clinical documentation truly support the MSDRG paid? If a hospital gets caught up in an OIG investigation, they are going to face a civil investigative demand, a CID. That means massive data pulls and federal subpoenas. And honestly, this often ends with a corporate integrity agreement, or CIA. A CIA mandates huge compliance overhauls, independent audits, and incredibly strict reporting protocols.
Okay, let's move right into Section 2, CDI query compliance standards and the AHIMA and ACDIS guidelines.
So how do we actually shield our organizations from these catastrophic audits? The answer lies in compliant clinical documentation integrity, or CDI queries. These queries are our absolute first line of defense. The official governing bodies, AHIMA and ACDIS, have laid out strict, non-negotiable rules for how coders and CDI specialists are allowed to communicate with providers when the documentation is ambiguous. Rule number 1, a query must be non-leading. You absolutely cannot hint at the answer you want. Number 2, it must be compliant, meaning 0 financial prompts or payoff language. Number 3, it has to be clear, concise, and grounded in actual clinical indicators found in the chart. And finally, every single query must be maintained as part of the permanent medical record, making it fully transparent and auditable.
Let's ground this in a real-world example. An illegal leading query sounds something like this. Dr. Smith, the patient's hemoglobin is 6.2. Can we code this as acute blood loss anemia? Guys, this is a massive compliance red flag. You are leading the physician straight to a specific, higher-paying diagnosis. You're effectively putting the answer right in their mouth. Conversely, a compliant, non-leading query sounds more like this. Dr. Smith, the patient's hemoglobin is 6.2 following surgery. Can you clarify if the anemia is acute, chronic, or due to another cause? See the difference? It's open-ended. It references objective clinical evidence, that 6.2 hemoglobin. And most importantly, it leaves the final medical judgment exactly where it belongs, with the physician.
To ensure that every query is legally sound, you really need to build it using a strict architectural structure. Think of it like a formula. A compliant query always starts with the patient information, name, MRN, date of service. Next is the clinical context, where you lay out the relevant clinical indicators like labs, vitals, or imaging results. Then you provide the documentation excerpt, the exact ambiguous or missing part of the record that actually triggered the query in the first place. Finally, you pose your open-ended query question. And here's a critical tip. If you are providing multiple choice options, you must always include choices like "Other, please specify" and "Clinically undetermined." Following this structure proves to an OIG auditor that you were genuinely seeking clinical truth, not just chasing dollars.
All right, that brings us to our final segment, Section 3, Quality Assurance and Audits, Establishing Systemic Defense. We've talked a lot about external threats and our daily operational shields, but the reality is world-class organizations don't just react, they build internal safety nets. They catch discrepancies long before an external auditor ever gets a glimpse of them. Building a solid internal compliance and coding risk matrix requires a multi-layered approach, utilizing 3 distinct audit methodologies. First up, we have retrospective audits. This is when you review completed charts and claims after submission to spot coding errors that cause denials or reimbursement loss. Next are prospective audits. Now, this is the gold standard for compliance. It involves reviewing charts before final coding or claim submission to stop errors dead in their tracks. And finally, concurrent audits. These happen in real time while the patient is still actively in the hospital. Concurrent audits are absolutely vital for validating present on admission flags and capturing missing documentation while the physician is still managing the case.
But here's the thing, just finding an error isn't enough. You have to fix the system, and you do that through root cause analysis and remediation. It breaks down into 4 steps. Step 1, identify errors. Is it a coding mistake, a documentation gap, or maybe a broken workflow? Step 2, analyze trends. Are we seeing systemic issues with a specific DRG or a specific provider? For instance, if your physician query agreement rates are consistently hovering over 90%, that's actually a massive red flag that your queries might be leading. Step 3, implement a remediation plan. This could be targeted training or specific workflow adjustments. And Step 4, follow up on monitoring via continuous dashboard tracking. Keep in mind, if your facility happens to be under a corporate integrity agreement, this monitoring will involve independent review organizations, or IROs. They perform mandated annual claim audits with very strict error rate thresholds and repayment obligations. And if you happen to find significant overpayments internally before an external investigation kicks off, organizations use the OIG Provider Self-Disclosure Protocol to proactively report it.
So, let's quickly recap our critical takeaways from today's explainer. Remember, upcoding is not just a little oopsie. It triggers severe False Claims Act risks and can force your hospital into a corporate integrity agreement. To defend against this, your CDI queries must be rigorously non-leading and strictly adhere to AHIMA and ACDS guidelines. And finally, maintaining a robust, multi-layered internal quality assurance audit matrix is absolutely your best systemic defense to protect both your revenue and your legal compliance. Coming up next in our masterclass, we'll be diving into Part 147, where we are going to discuss designing a world-class health system CDI and HIM operations architecture. You won't want to miss it.
And as a quick reminder, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.
I want to leave you with one final provocative question to take back to your teams today. I want you to really look closely at your daily workflows. Are your facility's daily queries quietly building a proactive, ironclad defense against federal audits? Or are they a massive compliance liability just waiting to be uncovered by the OIG? Something to think about. Class dismissed, and I'll see you in the next lesson.